I'll start off then, like with a question I often ask the audiences, which is, what is the health policy of the United States of America? And how much in dollars will we spend this year on healthcare? So if you know the answers, you can type it in the chat.
Walter, can you put this in presentation mode? You click the little screen icon just to the bottom of the right corner of your slide.
Is that better?
Yeah. Thank you.
So what is the health policy? Who knows what the health policy of the United States of America is?
Anne has an answer.
Yeah, what's Anne's answer? You guys can speak up.
Oh, we believe that healthcare is a business and that everyone, all the stakeholders should, except the patients and maybe some providers, should be able to make as much money as they can possibly wring out of the system. And if we leave a few people out, well, that's just too bad.
Well, that's pretty, yeah, that's kind of like how many of us think about it.
Yeah,
but I would say that since you're a more sophisticated audience, most people, when I ask them, have no idea because they have never actually thought about that question. And then the second question I asked, which is how much will we spend this year? I see that AJ has already figured out that it's a huge amount of money, something like $4.5 trillion. Usually I ask that question and people say, oh, 100 billion maybe, I don't know. Well, you know, like no one can even fathom $4.5 trillion or something like that. But if you ask those two questions together and think about it, what that means is that we are going to spend and tax ourselves something like $4.5 trillion. And we have no policy to decide how that money should be spent. And if there was ever a recipe for waste, fraud, and abuse, it's those two statements together. It's the idea that we would spend literally trillions of dollars on something that we have no idea what is the mission, what are the values, what are the reasons why we are creating this healthcare system. And that, frankly, should disturb all of us. So people who think about health policy talk about the Iron Triangle. Iron Triangle has three spokes: access to care, cost containment, and quality. And it's said that you can do 2 out of 3 in America, but not all 3. You can have the best quality healthcare system in the world, make it affordable, but you would deny it to millions of Americans. Or we could have universal healthcare with great quality, but it would be so expensive nobody could afford it. Or we could have very affordable healthcare for everybody, but in fact the quality would be so bad that nobody would want it. But in fact, the reality is that we want all 3. We want quality, affordable healthcare, and we want it for everybody. And the measure upon which any healthcare reform, such as the Affordable Care Act, such as any system we want to propose, is measured by how well it achieves the goal of quality, affordable healthcare for all Americans. And as AJ pointed out, the amount of money we will spend this year is astronomical. It's something close to $4.5 trillion, which is huge. But even more huge is the idea that by the end of this decade, we will almost double how much we spend on healthcare, which makes it literally unaffordable. So how much will we spend on healthcare for the next decade, let's say between 2020 and 2029? Here's a number you will never see in the newspapers. $51,783,000. Now think about this. The Inflation Reduction Act was lauded because it will save something like $300 billion over a decade in order to control mostly drug prices. But the denominator just in healthcare is something like $51.7 trillion. So only in healthcare can a $300 billion savings over a decade be a trivial, literally trivial sum of money. Now, who gets to control all these healthcare dollars? Well, the big hint is it's not you and it's not me. In fact, the people who get to control those healthcare dollars are very happy that most Americans don't know what the policy is, because they want to be able to control healthcare, and they want to sort of swindle the money out of us. And in fact, if you look at how we do compared to every other country in the world, there's something like a 2 to 4 year gap in life expectancy, and we spend 40 to 50% more per capita than any other country in the world. That is to say, we pay more and we die sooner for that privilege. And if you were a business person, you would have to say that this was a terrible model for healthcare system. And yet we can persist in having this model for healthcare for this country. And part of the reason is because there's no domestic issue that's more divided than healthcare. And part of it is because the pharmaceutical and insurance industry have their fingers into every aspect of our society, so that they have rendered it almost impossible for us to try to change the system. So this is a talk about single payer, and we should start off with a definition. I should start by saying that there is no one definition, which is both a blessing and a curse. But at its heart, most definitions characterize single payer as one entity, usually the government, that collects funds and then pays for healthcare on behalf of an entire population. That's it. It's simple. That's what single payer is. It is you collect the money and you pay the bills for everybody in a given population. And on the surface, if you think about it, that is a much simpler, much more rational way of financing healthcare for this population than this multi-payer, co-pay, co-deductibles, in-network, out-of-network, crazy, stupid, bureaucratic, wasteful system that we have in America today. So why don't we do this? Well, a lot of it depends on your feelings about government in general. So proponents are pretty simple. You collect the money, you pay the bills. But the critics are pretty clear also. That means you pay taxes, you're unable to pay for, we're not unable to pay for everyone, so therefore we have to ration care. It's going to be wasteful because government is always wasteful. And then you have to figure out that we have to cover these undocumented immigrants who shouldn't be in this country anyway. And so we go on and on. The whole point here is that how we think about this is a lot about our values as a society. Canada has figured out that there have basically 5 basic principles. It's publicly administered, it's comprehensive, it's universal, that's for everybody. It's portable from province to province, it doesn't matter, you can still get your health care. And it's accessible for everybody. And I think, you know, those basic principles are ones that we could embrace in this country if we were to have a single payer system. So most single payer plans have comprehensive health benefits. You can choose any provider, unlike the critics who think that, you know, they're going to ration care and you won't be able to pick your doctor. That's actually the exact opposite. They're describing the current system where you can't really pick your doctor because they may not be in network. But in single payer, you can pick any doctor you want. There's little or no cost sharing. It would limit the role of private insurance. It would set provider guidelines and standards. You would periodically review the benefit package. One of the great benefits is that you actually have a national electronic medical record system and billing system so that everyone, no matter where you are in the country, gets sick in California, you can live in Pennsylvania and your bills will be paid for. And in fact, we could actually track illnesses, like how many people with diabetes, how many people with disabilities, and we can actually use that as a way of planning where we should allocate resources in order to best address the health needs of a community. We would negotiate drug prices through a drug formulary, and we would put hospitals on a global budget. Now, many people talk about single payer, and single payer, if you start off your talks that way, you're going to end up talking about Medicare for all. Then people will say, oh, one size fits all, and then you have taxes, and then the private insurance role gets complicated. Are we going to take away your private insurance and your choices, and what about premiums? And anyway, what I'm saying is that you go down this rabbit hole, and before you even start explaining about single payer, you end up confusing most people in the lay public. I'm not talking about wonky people, but I'm talking about the lay public. And part of it is because we should reframe, I think, and I say this having given lots of talks about single payer, that maybe we should reframe it as saying a basic question, stepping back from, whether it's single payer or whatever, is healthcare a public good or a market commodity? We could just simply ask that question to the audience. Is healthcare a public good or a market commodity? Do we think the government's the answer, or do you think government's the problem? Do you think private insurance can't be trusted, or do you think private insurance, quote, works, whatever that means, for 176 million Americans? And to make things even more complicated, in English, healthcare has dual meaning. It means both the financing of healthcare and the delivery of healthcare. So, for example, you could say people like their healthcare, as Blue Cross Blue Shield frequently says, to their advantage because people think that way. Or it can refer to how we deliver healthcare. People like their healthcare. That could be a patient talking maybe about their hospital or their doctor. And this confusion actually would not happen if we had Chinese. Chinese, for example, would differentiate these two different meanings and have different characters and different pronunciations. But in English, we always say healthcare. And the insurance industry takes advantage of this. So for example, this is an ad from the Partnership for America's Healthcare Future. And it says Americans don't want a one-size-fits-all government health insurance system. And they put on the picture a cute little girl with a teddy bear sitting in a hospital bed. And of course, we want to believe that it's not the financing people, the insurance people who are doing this wonderful thing for them. In fact, they want you to believe that it's those insurance companies are the ones who are responsible for making this girl get better. But in fact, what they really don't tell you is how insurance really works. They're sitting in front of computer monitors deciding whether they're going to accept or deny your claims and adjudicate all kinds of other things, but usually having doctors arguing with maybe people who barely have a high school education, who have been hired to sit in front of those computer monitors and go down a series of algorithms to decide yes or no whether they're going to accept payment or not accept the payment for these services. So if we decide that healthcare is a market commodity, which many Americans think we have today, versus a public good, we have very different roads that we take. So if it's a market commodity, if you have no money, you get no insurance. It's that simple. Whereas if healthcare is a public good, everyone is covered regardless. If it's a market commodity, you say you require purchase of only private insurance. And the Affordable Care Act, by law, says in the marketplace, you may only buy private insurance. There is no public option available. So you have to only buy private insurance. What a great deal the private insurance companies negotiated with the Affordable Care Act. Whereas if it's a public good, you can pay what you can afford. If you're rich, you pay a lot more. If you don't make a whole lot of money, you can pay only what you can afford. Under market commodity, the shareholders own the for-profit insurance companies and the delivery system, as opposed to a public good where delivery is only responsible to the patients. Market commodity, you would rate your doctors and hospitals, whereas in public good, doctors are rewarded based on patient improvement. Under market commodity, we want people to do consumer-based shopping, so we charge you high copays and deductibles. That's uniquely American, whereas if it's a public good, there are no financial barriers. There are no copays and deductibles. You get the care that you need, regardless of your income. And we would, under NIH patents, under market commodity, we would hand it over, these patents that we spent all this money for research, to for-profit drug companies so they can make lots of money, like Pfizer and Moderna did with the COVID vaccine. Whereas under public good, we could actually keep those as public research and treatments that would benefit the American people. Now, the concept of public goods is not so foreign to most Americans, because if you think about it, our hospitals, our school systems, our wastewater treatment plants, our firehouses, even our national defense are considered public goods. These are things that are created that are not for profit for all, and they are funded by the word taxes. Even public health is funded by tax dollars. And those tax dollars that fund the schools, hospitals, wastewater treatment, and so on are essential parts to our society. And if healthcare is a public good, then actually it suggests how we might fund healthcare, which is that we would fund it through tax dollars. So under market-based systems, we create something called insurance premiums, which is the ultimate flat rate tax, if you think about it. And we can vary it by copays and deductibles. Whereas if it's a public good, you can base it based on ability to pay and income taxes. So if we were to transition to a single payer financing, right now a market-based system means that your wages are stagnant because the hidden cost of insurance is taken away from wages. And employers increasingly have to buy higher deductible health plans in order to keep their premiums level. And so that means the insurers keep offering skimpier and skimpier plans, which is why the benefits you're getting are terrible. Whereas if it's a public good, you could theoretically raise your salary by the amount of money that your employer pays for their premiums. And that usually is tens, thousands, maybe even tens of thousands of dollars. Can you imagine, you're going to work the next day and you have a $5,000 or $10,000 pay raise. And how do you do that? Because the employer stopped paying the insurance premiums and they give it to you as an employee. Now, in exchange, you have to pay taxes. But the taxes that you would have to pay would be far, far less than the amount of money that you would gain from that the employer gives you, the thousands of dollars he gives you from insurance, not paying the insurance premiums. Now, how might this look? So right now, the current system, it doesn't matter how rich you are. You make $600,000 a year, you pay exactly the same amount of money for the insurance premium. So a single person pays around $6,000 a year. If you make less than $10,000 a year, that's basically unaffordable for you. It's basically 30%, 60% of your income. Whereas if you make $600,000 or $400,000 a year, it's only 1% of your income. So who likes the current system? Obviously, the rich people like the current system because they only pay a small amount of money. But the poor people are hit with the ultimate flat rate tax, which is health insurance premiums that it numbers thousands and thousands of dollars right now that you have to pay. If we were to shift the curve so that actually healthcare was a public good, then instead of having the curve on the left where you pay a fixed rate amount regardless of your income, you would actually have a progressive rate tax. And the more money you make, the more you pay in taxes, but you can afford to pay more, frankly. You might ask, why would a rich person want to fund healthcare? Well, consider this story. One summer when you were in high school, you worked at McDonald's in Miami, and what did you learn about customer service? Well, I learned that it's really hard. I was a cook. They wouldn't let me anywhere near the customers. That was my teenage stage. They were like, why don't you work in the back? That was Jeff Bezos. He used to flip burgers at McDonald's in Miami. And the same healthcare system that covered Jeff Bezos when he was not so rich as he is today is the same healthcare system that would cover him today. And so the amount of money that he would pay, and he would arguably pay a lot more money in health insurance premiums than he would with a flat rate tax premium that he does now. But if he were to pay the taxes, he still could afford it. I mean, the guy's worth, hundreds of billions of dollars. And, the same system would have covered him when he was a cook. So the single payer term is actually been vilified by the medical industrial complex, by the Partnership for America's Healthcare Future. And they will do everything they can to make single payer sound like a terrible idea. And it's kind of a wonky term that's understood by policy types, but not by the public at large. So what about married people? Should they pay for healthcare? Well, It's not just single people, it's married people, it's everybody. The whole point is people get confused by the term. So wonky audiences like politicians and people like yourselves, you understand single payer. But for the public at large, I think we should change the terms. We should ask the question, should healthcare be a public good, or Medicare for all, because Medicare is something people understand, or as Chuck would say, one payer. There is a bill out there, HR 1976. It has 121 co-sponsors, including 2 Democratic leaders and 14 committee chairs. So the point here is that you can actually support this bill. And I hadn't finished yet, but I was just going through the list of co-sponsors to see how many of them got reelected. Virtually every one of them got reelected, and they got reelected by something like 60% of the vote in their districts. So the point here is that you can run on a single payer Medicare for all bill, and you're not going to get dinged or penalized for having done that. In summary, healthcare as a public good would be that prevention would be free and be funded like other public goods, such as through tax dollars, and it would be through your ability to pay. It would be through a progressive income tax. The real other advantage, I think, is this robust national health insurance database. It's embarrassing to me that we have Apple and Microsoft in this country, and yet we use CDC paper cards to tell us who's been vaccinated, how you were been vaccinated. Other countries have QR codes based on their national database. Other countries have to inform America as to how the efficacy of the vaccine. We had to go to Israel or the UK to decide what policy we should have for booster shots, as opposed to doing it here in America, because the insurance companies own the databases, not the national government, that we could have it as a single payer. And I think if we had a single payer and people believed in the value of the healthcare system, our attitudes about COVID vaccines would have been radically different than what we have in America, which goes along partisan lines. So anyway, that's my talk. I think I have a few minutes left, and I'll stop there.
Brilliant, brilliant, Walter. Thank you so much. Everybody note your email address for follow-up if a question occurs to you later.
How do I get out of this?
We might drop that in the box. If you can stop screen sharing, we can see the room.
Yeah, I'm trying to figure out how to stop screen sharing.
I think I can do it here. You
can do it?
Yeah.
Okay, good. Oh yeah, thank you, good.
Okay, all right. So a lot of us we dropped our video, but if folks want to come back in and have a very brief exchange here with Walter, folks have questions, comments, feedback, clarification on anything.
Great talk. Thank you.
And it's recorded, Mike, so we should, I think, segment it out and put it up. We want the Q&A recorded. So do folks have any questions? I mean, I can start. So one of the things that I think is undersold is just that single payer is a jobs bill. Is that it generates incredible economic activity and really boosts the overall economy. Can you speak to that, Walter?
Well, I think actually it would be the greatest thing for entrepreneurship. No one in kindergarten was, if you ask, what do you think you're going to be someday, says, I want to aspire to be a medical billing clerk. Nobody aspires to that in high school. You know, people want to be musicians or artists or, you know, whatever they want to do. Maybe they want to be a chemist or they want to be a business person. I don't know. But the point here is that you could pursue whatever you want if you actually were covered with health insurance, as we would with a single payer or healthcare for all public good system. And nobody really wants a job like in this billing system that we have that is just ridiculous. No, it's not what people really want to do in their lives. And I think, you know, if we had a system where health insurance was covered, it would be the greatest entrepreneurship thing that we could do for Americans. And it would unleash all this creativity that's out there in the American people so that they can pursue, and they wouldn't be stuck in job lock, which the current system fosters. Because, you know, people say, oh, I have to do this terrible job because I have to get their benefits. I mean, nobody wants that.
Actually, PNHP has a great slide. So Alex just asked whether they have retraining and stuff. And all the bills include retraining or some just transition, I think they call it. But PNHP has this great slide where what they show is that there's so much flux in that profession already, that the numbers who are going to, you know, the 2 million or whatever million are going to be put out of a job is so much less than the number of people that just move or, you know, quit or are fired in a given year. I mean, it's just a wonderful slide. And
that's a good point.
Everybody brings it up. You don't give any talk where somebody doesn't say, well, what about all the people that are working in that stuff? And there is retraining, there's plenty more jobs and stuff like that. But anyway, what really struck me is how small it is compared to the flux in the system to begin with. Anyway, sorry.
The other questions, so I won't comment.
Other people were polite.
Okay, all right. Thanks for that, Alex and Barbara. Mike and then Catherine.
Yeah, I think we have to be nuanced about tax the rich. I think Warren George reports that 80% of the healthcare costs are now paid by the top 20% earners. And if you're not careful about this, in Oregon, we were thinking about taxing a progressive tax, and we would scare off all the doctors, so to speak. If it's not done very carefully, you have to just be sure that you're not punishing one group more than another, even in amongst the wealthy.
Well, I guess I'm not that sympathetic. Everybody, it's not just doctors. It's lots and lots of people, all right, who are very rich, and I'm not taxing all their money. I'm just saying that let's take 25% of it, let's say, toward health insurance premiums and other public goods in society, just like, you know, roads and bridges. And that money then is divvied up. Some of it goes to healthcare, some of it goes to national defense and other things. But you know, we have to pay our bills, and healthcare, if we split it up amongst the, you know, so that the rich pay a little bit more than what they currently do, they've gotten such a good deal up to now. I think, you know, we would all benefit as a society. So.
I agree.
Yeah. I understand what you're saying, like it's Michelle, but I do think that there's a way to talk about it that threads the needle, so to speak. And yeah. I think that definitely one of the things that we want to talk about is that so many people are attached to healthcare in their job. Like a year and a half ago, I was so ready to leave my job, which I finally did, thank goodness. But I even saved up money, and then I realized I had no money for health insurance. And if I left my job and I didn't get something soon, I would have no medicine and probably die. So then I stayed at my horrible job for another year. I do think that there's a huge attachment and stuff. And I do think that there are going to be people, especially at nonprofits, because that's my sort of thing, that are going to say, you know, I have good, quote unquote, health insurance through my job. And I don't want to lose that for something that's uncertain. But I do think we can talk about the fact that, you know, with a single payer option, your job can give you different types of benefits, like maybe things towards childcare or more time off of work that it currently can't give you now to attract you or retain you because it has to spend money on healthcare. So I think there's ways to get around that and stuff, because I do think there will be pushback from at least from the nonprofit sector and stuff, because usually the only good thing about it is the health insurance. And so, yeah. But I do think we also need to talk more about public good, because I do think it's the way you see it. And because we're such a capitalistic country, it's very hard to understand or to see that this is something that, even if you personally feel like you're not going to be affected, is a good for everybody else. Like, we can see it in some ways, like roads, because that's very obvious, but it's hard for us sometimes to see it in other ways. So I definitely think that no matter what we do, the idea of a public good, even if it's a part of the public you don't love, is something that we need to keep talking about.
Mm-hmm. Yeah.
Thanks, Michelle. See, Catherine had her hand up. Catherine?
I just wanted to mention that, well, first, in regards to Barbara Pearson's comment about people who, there are so many people that do leave that insurance industry, especially the claims industry portion of it, because it's so stressful having to listen to all of the horrible stories from people, and to know that they're the ones that are like denying those people, you know, and they just can't take it for very long, and they quit. And then the other thing is too, when Mike was talking about we don't want to make the rich people, get them too mad. It's like, the thing is, most of those people who think they're rich, those are not the rich people that we're talking about taxing. With our whole Washington plan, you don't start seeing people actually paying more for the benefits till they are making more than $500,000 a year. And so it's really, when you start looking at there's a lot of people who think they're rich, but those are not the people that we are wanting to tax more for, you know? So, anyway, okay.
Thank you for that clarification.
Yeah, there's a lack of class consciousness,
Mm-hmm.
a lack of class consciousness that's really underlies part of our problem. Ann Jones.
Yeah, so a couple of your slides are very powerful. That how, because I haven't seen a good way to show it, how regressive premiums are for different income levels with employer-sponsored health insurance. Whether if you're making $30,000 or $150,000 at the same company, you're paying the same amount of money is being essentially taken out of your income for these premiums. And I don't think people understand that at all. And the other one is your slide that shows these tables and, you know, I don't know, insurance company employees, as you pointed out, with no training, no education, absolutely no medical background for the most part, making decisions about what they will cover and what they won't, which is essentially a decision about your health care because of our system. We could use that to counter this government run, government making decisions about. These are the people who are making decisions based on some insurance company protocol having nothing to do with your actual health status, or problems. Think about that. How can we make that more powerful? These are the people who are making decisions about what you can and can't get.
Yeah.
Not your doctor, not your team, not somebody who knows you, somebody with no training, whose motive is profit. Their job is healthcare as a insurance company, is a business.
Right.
We got to make that a more powerful statement to counter that.
Wow. If you come up with a good slide, let me know.
That's great.
This is meant to inspire us to think, be creative in how we want to, approach it.
Well, I think we need to switch up for profit, and we need to replace it with profit first, because it's built into the system.
Profit before patients.
First.
Yeah.
Right.
Profits before patients. Health insurance is a business. It has nothing to do with your health.
Right. Well, that's all institutions anymore. Lydia?
Yeah.
I want to ask Walter, could you say a little more about hospital global budgets, and when you said the databases are owned by the insurance companies, just more language for me? I would like that.
Well, the global budget part, right now you get an itemized bill if you're hospitalized for every catheter and drug and so on. And it could be several 100 pages, who knows? If you put people on a global budget with the idea that everybody who's in your catchment area is covered by the health insurance plan, you take all comers. You don't discriminate based on whether they're really sick and therefore we don't really want to take care of them versus, the worried well who you like because they're simple patients to take care of. You take care of everybody. And I think that you can do that if it's a public good. But in the current system, the market-based system, a lot of people simply don't want to take care, are maybe unable to take care of people who are really complicated. So that doesn't mean that, we shouldn't have some higher tertiary facilities. People know which facilities have better expertise in certain illnesses. But the current system is based a lot on the type of insurance you have and whether they want to accept you or not at a hospital level. And that's wrong. I don't remind me of the second question you had.
About the insurance companies owning the databases.
Oh, well, right now, the insurance, when you put in a claim, that goes to United Healthcare or Aetna or Blue Cross Blue Shield or whatever. They have the data on that. Do they share that with the government? Well, some things they share, but I find it embarrassing, at least in my state, the number of people who had the COVID vaccine, they were off by something like 50,000 people or maybe even more. We have no idea how many people have died in COVID in America. Mm-hmm. We have no idea how many people have long COVID in this country. We have guesses, but if you had a true national database, you should be able to figure some of this out with a lot more accuracy than we have now, because the insurance companies don't necessarily share that information because they consider it proprietary in some way. And I think that's wrong. You can't really do good planning. Imagine if you knew where all the diabetics were concentrated in your state, you could put more diabetes resources, more, change the food deserts in those areas, have more nutritious foods available. You could do this in a real public health planning way that we are unable to do in America today.
Thank you, Walter. AJ, is your hand up?
Yeah, Walter, excellent discussion. It's always good to hear you. How do you sell public good? How do you sell it to the average people?
I mean, healthcare is a public good?
Yeah.
I think that's intuitive. If you contrast it to whether it's a market commodity versus public good, I think most Americans intuitively would say, I think healthcare should be a public good, because they know what it means to have healthcare as a market commodity. It means they get to charge you whatever they can get away with, frankly. And they have all these convoluted systems about in-network, out-of-network, co-pays, co-sharing, deductibles, all these terms that are uniquely American. And I think Americans are totally confused by this. If healthcare was a public good, it would be a lot simpler and a lot easier to understand what your benefits are and what you should have covered, namely everything, basically. So that's why I think we should step back and say, is healthcare public good or is it a market commodity? And if you get most of the audience to believe that healthcare is a public good, the sell for single payer becomes a lot easier, frankly.
Okay, terrific. Thank you. Michelle, is your hand up?
Yes. So I just wanted to know if you had any good places to go to find out more about housing insecurity and healthcare and the need for single payer for that particular population of people, because that's the population that I work with all the time, and also more about single payer and mental health and harm reduction, substance abuse services. Like, are there good places to go to find out more about that? Because for my life, that's probably the biggest push or the most important thing?
Well, I just got this email saying that they're going to have a webinar exactly on this topic about housing and its intersection with public health. And housing first is actually a concept that most of the homeless programs in this country accept, because until you have people stabilized in a place where they can reside, it's very hard to address any of their health needs. But once you have some type of housing available to them, then you can talk about treating their illnesses, figuring out what kind of modifications we might need to make if they have some type of disabilities, what kind of mental health treatments might be best for them. But it's very hard for them to do this when they're homeless out in the streets and trying to survive on a day-to-day basis. So I accept the idea that housing first is an essential role that precedes our ability to really address their healthcare needs. Once we can get them housing, we can start dealing with many of these other issues that complicate their lives. And I'm going to find that webinar and send it to you, Michelle. You might be interested.
Thanks. I would love that and stuff. And it's just good seeing you again. So.
Yeah, I'm sorry you don't have your camera on because I like to see you.
Okay. Oh, I'll put it on.
There you are.
My battery space. But for you, Walter, I'll put it on. Battery space, battery charge be damned.
Okay. I don't want to waste your battery. Okay.
That's okay.
I think we're done, actually, are we?
Yes.
I believe so. I don't see any more questions outstanding. Just to give you applause, Walter. These great talking points, ideas to carry forward. Bravo. Thank you. And for coming in, on pretty short notice. I gave you a heads up a while back, but didn't reconnect until yesterday. So thank you for doing this. Appreciate it.
Well, you're more than welcome. It's always fun.